Hello, today we are discussing about abortion, and we will be interested in understanding how you can be able to define abortion, especially in the context of Uganda, and how we can be able to make the diagnosis of abortion, both looking at the symptoms, how different types of abortion present, and also looking at how you can actually make it, especially the signs that you're able to deduce when you're doing a physical examination, especially a vaginal examination. We'll also look at how you'll be able to deduce different differential diagnoses related to abortion, and also the various causes or risk factors associated with loss of a pregnancy. Abortion, also described as miscarriage, is the loss of a pregnancy before the age of viability. In Ugandan context, the age of viability is when the baby is less than 28 weeks of gestation. Although we have also seen that a number of babies who are born just before the age of viability can actually be able to survive. Like the local statistics that shows that babies born at 25, 26, 27 weeks can actually have a chance of surviving. This calls for a change in the mode of in the model of management of abortions, especially when they are near 28 weeks. So that means that this kind of miscarriage, if they will ever happen, they should be able to happen in a setting where they're able to do a neonatal resuscitation. It's a common condition, account up to 20% of all clinical pregnancies. More than 75% of this occurs before the age of 16 weeks of gestation, and this rate higher as the mother's age is increasing. And also it increases with the history of previous miscarriage. We have abortion divided into a number of conditions. It can be spontaneous abortion, which is actually the one we are interested in telling you. When you're talking about abortion, we do not mean intentional termination of pregnancy. Intentional termination of pregnancy, it's actually an induced abortion. So when you're talking about abortion, it means that you've lost a pregnancy. In some contexts, people call spontaneous abortion as a miscarriage, but all of them you've actually were able to miscarry the pregnancy. Spontaneous abortion can be isolated. That means that it can occur maybe because of specific problems and may not actually repeat itself. And then it can also be recurrent pregnancy losses. That we'll actually briefly look at it at the end of this presentation. Induced abortion, on the other hand, can be because of medical termination of pregnancy. Maybe if a mother has a condition that is making, if we continue with the pregnancy, we're going to end up into a problem. We can be able to discuss that on case-by-case basis. But there's also others that are called illegal. That means that people do this for reasons that are not prescribed or reasons that the law does not allow, especially in the context of Uganda. What causes abortion? It could be because of fetal factors. It could be because of maternal factors. The fetal factors may be because of the genetic issues. So if there is a problem with the gene of the baby, of the fetus that is being formed, there's a high chance that mother is able to lose that pregnancy. The other thing is that up to 50% of babies are lost due to maybe chromosomal abnormalities. So that should also, we should take that into context when we're investigating a mother who has actually lost a pregnancy. Numerical defects like trisomy, if you have trisomy or polyploidy, that means that you have an extra copies of chromosome being present that may actually result into abortion. Monosomy, that means that you've lost one copy of a particular chromosome of interest. That means that it can also result into that. Structural defects, if there's a defect in the chromosomes, maybe part of it has been lost, you actually likely to have this. Multiple pregnancy is also prone to miscarriage. So when a mother has a multiple pregnancy, these are high-risk pregnancy that need to be looked at closely. The other thing is that when you have the placenta degenerating, the villi degenerating, you're also more likely to have that. Maternal factors that are related to abortion could be because of endocrine problem or could be because of anatomical abnormalities. The endocrine problem account to up to 15% of cases. Even the anatomical abnormality account for up to 15% of the cases of pregnancy losses. The endocrine problem could be because of diabetes. When a mother has diabetes, they are more likely to lose a pregnancy. So that means that a mother who has diabetes and attempting to conceive, you may need to actually have a closer look at them. Thyroid abnormalities, even in a phase that you have luteal phase defects, you're more likely to have this. We'll have a discussion about luteal phase defects in another lecture. The other anatomical things that might predispose a woman to getting a pregnancy loss could be because of cervical factors or uterine factors. The cervical incompetence is one of them, or insufficiency. Congenital malformation of the uterus, that we'll actually look at it later. Uterine fibroids, when you have especially submucosal uterine fibroids, you're more likely going to lose pregnancy. And intrauterine adhesions, that will actually limit the expand of the uterine volume. So you more likely have issues with your pregnancy when you have that. Importantly, we need to note that infection account only for 5%. And in many clinical settings, people, when they have a miscarriage, they are more likely going to look for what is causing that, and they are interested in looking at infection, which is very unfortunate. Of course, it accounts only for 5%. Immunological disorders also account up to 15%. More than infection, we have the autoimmune diseases, especially the rhesus isoimmunization, if it is there. If you develop rhesus isoimmunization, you're more likely to have that. And then other autoimmune conditions that can actually predispose to that. We also have environmental factors, cigarette smoking, people who take a lot of alcohol, people who are taking contraceptive agents, especially when they're pregnant, they're also more likely to lose the pregnancy. It should be noted that this contraceptive agent is only when you're pregnant. When you take it when you're pregnant, you're more likely to cause, you're distorting the hormonal milieu within a woman's body. Maternal medical illness like cyanotic heart disease and hemoglobinopathies are more likely to also have this. Also, we need to know that up to 20% of the pregnancy losses have no demonstrable causes. So the causes are actually unknown. Let's look at the specific types of abortion. We have threatened abortion. In this has started, but has not progressed to a state in which recovery is impossible. So you just having someone having a situation when they're about to lose their pregnancy, but they have not yet lost the pregnancy. So that is also something that you need to know. It is present, and yes. So in this case, you can be able to manage this patient, and then maybe the miscarriage, the abortion thing will actually regress. It may actually regress. The other clinical features associated with this is that the patient have normally history of amenorrhea. Of course, amenorrhea is a constant. Then they have a slight PV bleeding and a slight pain. This pain and PV bleeding should be slight, but in most cases, the PV bleeding is actually painless. So initially there will be painless, but maybe it will progress to a mild back pain that is dull, and also lower abdominal pain. In this case, when you do a digital examination, you find that the cervix feels soft and it is closed. The external also of the cervix is closed. And if you do an ultrasound scan, it may actually reveal that the cervix is actually within a normal range. But of course, there may be some bleeding that is seen behind the placenta. So that could be a threatened abortion. Of course, if in a threatened abortion, you need to have differential diagnoses that are there. The differential diagnosis may be cervical ectopy, maybe polyps, orocarcinoma, ectopic pregnancy, molar pregnancy. These are things that you consider when you think a woman is pregnant and they're bleeding, and you want to be sure that they don't have any other condition. The management of threatened abortion is best. Of course, the patient should have bed rest. Up to 80% of this pregnancy may actually be able to continue until term. Of course, the relief of pain you may actually be able to, and then maybe because of anxiety, you may need to calm them down by giving diazepam, but that's not quite necessary. Of course, the other thing is that if the pregnancy, if you see already a live birth, a live fetus, I mean, not a live birth, a live fetus, the chance of carrying it on is 95%, and which is actually pretty good. Let's look at inevitable abortion. In this case, changes have progressed so much that pregnancy it is not possible for the pregnancy to continue. That means that you may not avoid this kind of pregnancy loss anymore. Clinically, this patient have features of threatened miscarriage, which initially was present, with increasing vaginal bleeding and aggravation of pain. So the pain becomes more and more. That means that the uterus starts contracting to expel the product of conception. Sometimes these features may not develop typically with threatened abortion. It will progress so fast that it is hard to even help out. If you do an internal examination, a vaginal examination reveals that the cervix is already dilated with the product already in the cervical os. So when you have that, if you see this picture, it shows a threatened abortion. That means that the implantation side is already detached. There's complete detachment. Whether you do what, you may not be able to re-implant this. So that means the only thing is you help the mother to avoid bleeding. The management is aimed at accelerating the process of expulsion. That means that you don't need to expect much apart from completing the process. And also maintain strict asepsis so that the mother does not get pregnancy. It's important that you need to take this seriously. Sometimes you would want nature to take its course, but it might be predisposing a mother to something else. If a mother is, if the pregnancy is below 12 weeks, you may consider suction evacuation with MVA. But if it is 12 weeks and more, maybe you consider a forceps evacuation or oxytocin infusion. Oxytocin is less likely going to work because the receptors are not yet present at these times. Of course, IV fluid, you may need to consider that. If the bleeding is much, you may need to consider blood transfusion, among others. Antibiotics you may need to consider. Incomplete abortion, the process has already taken place, but the products has not completely been expelled, and part of it is left inside. It could be the placenta, it could be the membranes, it could even be the fetal part still being left inside, and that's what we call incomplete abortion. In incomplete abortion, typically it presents with history of fleshy mass per vagina, so that these women will tell you that yes, they have lost some product of conception. The pain may continue, and then the bleeding may actually continue. If you do an examination, it reveals that a uterus is smaller than the period of amenorrhea. If the woman is probably about 14, 15 weeks of amenorrhea, and then when you do a vaginal examination, you find that it has actually reduced, it's less than that. The internal os of the cervix may still be open because the product is still within the uterine cavity, and there may be still bleeding that you'll be able to see coming through. On examination, you may actually find that if you were able to recollect the product of conception that has been expelled, you'll actually find that it is incomplete. The problem with this is that the retained product may cause bleeding, sepsis, or placental polyps. So it's important that we remove it. We actually do evacuation. And that's how it appears on the picture. The management, of course, is evacuation. Early abortion, dilatation and evacuation under anesthesia is very important. Sometimes with the time the cervix will get closed, so you may need still dilate and then evacuate. For late abortion, that's more than 12 weeks, you may need to do it under general anesthesia, and then you use ovum forceps and other blunt curettes to actually get this product of conception out. So you may need to consider giving prophylactic antibiotics. You need to consider medical management with misoprostol, and then these are things that you need to do. When the product conceptions are completely expelled from the uterus, it is called a complete abortion. So a complete abortion is when everything has already gotten out. Then that is it. And then the picture is that there is subsidence in the abdominal pain. As soon as she expels everything, the pain will reduce, and even the bleeding will actually reduce. The size of the uterus may actually reduce. The cervix will be closing up, and then the bleeding is actually very minimal. It's just almost menstrual-like. If you do an ultrasound scan, you find that the endometrium is already empty. A missed abortion is when the fetus is dead and retained passively inside the uterus for a varied amount of time. When it is diagnosed normally when the fetus with a crown round length of 5 millimeters without a fetal heart. So sometimes this, when it is too early, we call them a blighted ovum. But a missed abortion is when the fetus is died inside, but is still retained. And the clinical features of missed abortion are very key, very clear here. You realize that the signs of pregnancy will start disappearing. If a woman was vomiting, this vomiting will start disappearing. If they have tender breasts, it will start disappearing. If they have breast engorgement, it will start going down. The uterine size become also smaller and smaller, and then the cervix feel firm with closed internal os. So when you do an internal examination, you'll be able to have that. If you look at the fetal heart, you will not be able to see that. And with the time, if it takes long, really long, the immunological test for pregnancy may actually be negative. So if test for pregnancy, it may not be seen. If you retain this product for conception, it might lead to complication of sepsis or a disseminated intravascular coagulation. A rare thing is that though it is very rare, but it can occur for babies above, for fetus above 16 weeks of gestation. Of course, the management here is that you need to evacuate. If it is less than 12 weeks, you need to consider. There are changes that are done, and I think this you'll actually see it from the word, what is being done on missed abortion when they come. A septic abortion is when the infection has actually entered into and infected the product of conception within the uterine cavity. This is something which is gross, and it can lead to a lot of complication. And if anything, it should be avoided. Most of them come because of retained product of conception, and maybe because of also a missed abortion. So if a missed abortion is detected earlier, it should be worked on earlier. If a retained product of conception is there, a mother came in with a retained product of conception, it should be cleared. The clinical features, of course, your mother's present with vomiting, diarrhea, and then the pulse rate will also increase, and then because of sepsis. If you do an abdominal examination, realize that there will be abdominal tenderness and then guarding and rigidity. Internal examination reveals offensive purulent vaginal discharge, and then uterus usually will be pantulous or boggy. So that means that they are not contracted. The cervical os will normally be open. In this case, septic abortion, if you must do investigation, these are the key things that you need to do. A complete blood count would help you to see maybe if there's increased leukocytes, and then the different leukocytes that are increasing. And then you may need to look at the serum urea, creatinine, and electrolytes. A septic abortion may actually cause septic shock, and then may actually cause renal failure. And that may affect the amount of creatinine, urea, and then probably even electrolytes will be affected. You may need to do a high vaginal swab to see what kind of organisms are actually involved in this kind of infection. A blood culture would actually help you to rule out septicemia. A transvaginal scan, pelvic scan to detect retained product from conception is very important. If maybe you suspect a boil injury due to the perforation related to abortion treatment, you may need to do an abdominal X-ray. Complications, especially with abortions, can be immediate complication that may be because in terms of hemorrhage, injury, maybe to the uterus, adjacent structures, maybe spread infection that leads to generalized peritonitis, endotoxic shock syndrome, and especially when you get infection due to E. coli. You may also get disseminated intravesicular coagulation. Acute renal failure, already talked about it, and thrombophlebitis. That means that you have a thrombus formed on the veins. All this leads to increased maternal death. So you may need to know that abortion is one of the major causes of maternal death in Uganda. Management of septic abortion, of course, you consider mild cases, you may need to consider antibiotics, and in severe cases, you may need to admit this patient and then manage them symptomatically as much as possible, as well as you're trying to do evacuation. You need to do this evacuation as soon as possible, but you do it after initiating a mother on antibiotics already. That's basically about abortion, but let's also look at recurrent abortion, which account for up to 1% of all women. 1% of all women actually have recurrent pregnancy loss. That means that 1 in 100 of them would actually have a problem with current pregnancy and may actually have losses of pregnancy as defined by recurrent pregnancy loss. The risk increases with each successive abortion. So the more abortion you have, the more likely you're going to have a recurrent pregnancy loss. In some cases, up to 50% of these mothers present with no demonstrable cause. So first trimesters pregnancy loss, recurrent pregnancy loss. It may be because of the gene, it may be because of translocation of the chromosomes, it may be because of other factors that affect the chromosomes. It may also be because of endocrine or metabolic disorders. Like in a patient who has poorly controlled diabetes, they are more likely to have recurrent pregnancy loss. Thyroid problems, we already said luteal phase defects is one of them. And then this polycystic ovarian syndrome, here abbreviated as PCOS, is also very key in causing recurrent pregnancy loss. Infection, although a rare thing, may actually cause recurrent pregnancy loss, especially syphilis. And then if you have a genital infection that can go through the placenta and infect the baby, you're more likely to have that. In mothers who have inherited thrombophilia, that means that they have bleeding tendencies, especially when they have a protein C deficiency, protein S deficiency, and protein 5 Leiden mutation, or a prothrombin gene mutation. They are more likely to have problems with recurrent pregnancy loss. You may need to understand this well, and then you go to the coagulation pathways. If you go to the coagulation pathway, you understand where these proteins C and S are, and then the factor V Leiden, and then the prothrombin. This will give you a guide. But in summary, is that if these mothers have bleeding tendencies, as the fetus is implanting itself, it may create some erosion on the maternal surface, and this may cause bleeding. And if you have bleeding tendencies, the bleeding may actually continue until the sac is displaced, and that may result into abortion. Immunological causes may be because of autoimmunity. We must understand that pregnancy, the fetus inside is foreign. So if a mother has already autoimmunity, they are more likely to reject even a foreign particle, a foreign gene inside them. If they're already fighting their own gene, so that means they even fight the foreign gene better. So this may actually result into pregnancy losses. Of course, you have conditions that have classified as autoimmune disorders, like the antiphospholipid syndrome, and then systemic lupus erythematosus may also cause that. If the pregnancy loss is within the second trimester, it may be because of anatomical, it may be because of acquired defects. It may be congenital defects or acquired defects. The acquired defects may be because of adhesions that is created within the uterine cavity, especially Asherman syndrome. And then you have uterine fibroids and endometriosis that may also affect this and distort the architecture of the uterus, and then the cervix and cervical incompetence. The congenital, will actually look at them later. The uterine causes account for up to 12% of recurrent pregnancy loss, maybe because of Mullerian fusion defects. You need to review a Mullerian duct, how it develops into the cervix, the upper third of the vagina, the cervix, and then the uterus, and then the uterine tubes. So there may be anomalies in their presentation, and that may cause a problem. It may also be because of implantation onto the septum. If you have a septed uterus, if you implant onto the septum, it has a poor blood supply, and then that pregnancy is more likely you're going to lose it. This picture shows you uterine anomalies. You see that this is a septed uterus. There's a septum that is formed between it, and then we have a double uterus. That's actually what they call uterine didelphys. Uterine didelphys, you see that there are two of them. You may also have a biconate uterus. That means it has two horns. And this one here is not only double uterus, but you see that there's also double vagina. The vaginal pouches are different. Each of the uterus has its own vaginal pouch. Cervical insufficiency or cervical incompetence normally occurs, this pregnancy losses occurs in the second trimester, or even it can cause early labor. So that means that you're more likely to have a preterm labor. The cause of this can be because of congenital, when people have congenital development of the uterus, especially Mullerian issues, they may actually have a uterine, cervical incompetence. It could be acquired, and when you're taking history of a patient with cervical incompetence, we would actually be interested in especially the acquired causes if they've ever had a DNC, dilatation and curative operation. If they have induced abortion, maybe by dilatation evacuation, it's very important that you need to understand that. You may also need to have vaginal operative delivery through undilated cervix. So if they have an operative delivery, maybe they did a vacuum, maybe they did a forceps delivery. Very important that you need to put that. If they had amputation of the cervix, maybe because of corn biopsy or something else, it would be good to have that. And then multiple gestation prior preterm birth. If you have multiple gestation, you're more likely to have a cervical incompetence. And in some practice, when a woman has twin or triplet, they actually put for them a cerclage as a prophylactic ways of preventing pregnancy loss. The history is that these women present with mid-trimester painless cervical dilatation and the escape of liquor, amni. So normally they start draining water, and then the water, you realize that by the time they start draining water, probably the cervix is already dilated more than 4 centimeters. If you do an abdominal examination, especially if you do Ega dilators, if you pass Ega dilators when the woman, before the woman is pregnant, it can actually allow up to size 8 of Ega dilator beyond the internal os, and that means that probably. And if you do hysterosalpingography, you see that there's funneling of the internal os. During pregnancy, of course, there may be certain things. The cervix may be short, less than 2.5 centimeters, and there may be funneling of the cervix, and then the internal os may be only less than 1 centimeter. So you may need to rely this if a woman is already pregnant. Management of this is, of course, you need to put a cerclage. You need to put a cerclage, either Cervical or McDonald. You will understand this cerclage as you go to the wards. And this is how it presents. Normal competent cervix should be long enough, and then it should actually have a T shape. You see this one forming a T. And then in the cervical incompetence, you see that this one here is forming like a U now. So that means the cervix is already opening. This is how you're able to restore the cervical incompetence. And these are the contraindications of cervical incompetence incision. And then you also need to look at the type of cerclage that you give. And then these are the type of cerclage that you do. Not very important for you now, but it will be good for you to understand them. That is the Cervical. You have to actually dissect. In Cervical, you have to dissect the cervix and bury the sutures below the cervical mucosa or the cervical skin. In cases where mothers have failed, and especially if they have failed cervical cerclage twice, you may actually need to consider a transabdominal cerclage. it's a difficult operation. It's very invasive. You may only reserve it for mothers who have failed, or when the cervix is so short that you cannot even put a cerclage. A postoperative care, this is what you need to do in the postoperative care, and when you should remove the stitch is well illustrated here. You need to remember that. The complication that are shared with the stitch are here. You need to see that. Prognosis, recurrent pregnancy loss. Of course, this is how it can, how the prognosis. The risk of recurrent pregnancy is about 25 to 30%, irrespective of the number of previous spontaneous miscarriage. The overall prognosis is good even without therapy. Sometimes actually mother can have a miscarriage, and then you may actually have a success of more than 80%. And basically that's what I wanted to discuss about cervical. About cervical incompetence, and also about abortion. So I encourage you to read, and I expect that I'll get more questions when I come to the ward.